Hello and welcome back to Bedside Murmurs, a podcast where we chat with doctors about their careers, pathways to medicine, clinical tips, and much more. If you have any questions or have any ideas of guests you would like to see on the show, please send us a message at podcast@medsoc.org.au or direct message us on Instagram at Bedside Murmurs. I'm Sean.
And I'm Emily, and we will be your hosts. Today we are excited to speak with Dr Rowena Mobbs, who is a clinical neurologist. She is a leading clinician in concussion, chronic traumatic encephalopathy, and dementia services. Dr Mobbs was the founder and director of the Australian CTE Biobank. She completed a PhD on cell death in neurodegenerative changes in acute and chronic compressive myelopathy and has twice been awarded the Spine Society of Australia Award for Research. Dr Mobbs' vision is for the expansion of collaborative and innovative neurological services in dementia, which is one of the Australian national health priority areas. So welcome, Dr Mobbs. It's a pleasure to have you here with us today.
Thank you. I'm so excited more than ever to be here.
So we'll start at the beginning. Where did you go to medical school and what was that like?
I went to Adelaide University Medical School. I grew up in Canberra, so we didn't have a med school in those days. I think it's different now. So I was really hunting for the best cricket ground in the country, and Adelaide was it. It was the old cricket ground. I went to the Ashes. I went, this place is for me. Fell in love with it instantly. And Adelaide was such a cool place to be. It's got a really, centre, real heart and soul, lovely food, a little bit of wine, great medical school, not too small, not too big, a lovely mix of people. And I went to college at St Mark's as well there. So a lot of fun, really traditional didactic learning, but mixed with a bit of problem-based learning in the early days. And it was an undergraduate course. And the rest is history.
And what did you enjoy when you were at medical school?
So I really early on knew I loved the brain. So I was tossing up really early, am I going to be a psychiatrist, neurosurgeon like my father, or neurologist? And I worked out pretty quickly, I didn't actually know anything about illicit drugs. So it's just not really my sort of thing, and I'm not really streetwise. So I was like, well, maybe psychiatry's out. And I wasn't really good at diagnosing schizophrenia from schizoaffective, although I was really interested in it. And I did do a good 6-month term as a neuropsychiatry block. Neurosurgery, you've got to stand up all day, there's no coffee. It's really interesting field, but, it involves screws and, metalwork, and I didn't like going to Bunnings and doing handy stuff at those times, so I do now, but I was like, this isn't for me. Neurology I love because it was such a mixed bag. It's variety, and variety is the spice of life. I used to see it as almost a lucky dip. That's probably the wrong term because the poor patients, of course, but every patient and the family was different, and I loved that diagnostic challenge. It was detective work and a lot of visual detective work. I'm a very visual person, so it's like out of the corner of the eye, what do you see when a patient walks into your waiting room? How do they handle the pen? What's their conversation like with the family? And to this day, I just love being a clinician. Mainly the research is there, but fundamentally day to day every case is different, even if it's your garden variety Alzheimer's. So I just instantly love that. And so 4th year med, I decided to do neurology. And I thought as well within neurology, the brain is much more interesting than nerves, neuropathies, myopathies, that sort of thing. I liked learning that, but I knew I was going to be a cognitive neurologist pretty early on. And when I started to do that training, it wasn't really that much of a subspecialty, cognitive neurology. It was sort of like a few people did it, maybe, and that was it. It was left to the geriatricians.
This is going to be so random, but what was it like having a neurosurgeon father?
Oh, yeah. It was intense. Yeah. So I always had this spectre above me and neuroticism of wear a helmet when you're riding a bike. And,
oh my gosh. Yes. I can totally imagine that.
Ingrained in me. But despite that, I did do horse riding and pentathlon, and I played hockey.
Wow.
Very brave neurosurgeon father.
Yes. But I did ask when I was 11, Dad, I'm desperate to play soccer. And he said no, and he didn't tell me why. But at that time, he was actually leading the concussion protocols nationally with all the football codes, and they were all in agreement on a 3-week rest after the concussion, and they were worried about the long-term effects. And I'm pretty sure it was that for which he said no.
They drew the line at soccer, but not horse riding.
Yes, so funny. I know.
Sure.
But actually my sister did end up in his unit having not worn a helmet, riding her bike and fell off. But it was great. Like he was, it was long hours. Gosh, it was the first round of the neurosurgeons in this country. Like it was a young specialty, 1950s.
Okay.
Australia came up with and advocated for helmets. There were, probably certainly less than 50. I think it's more like 20 or 30 surgeons in those days. And he established the neurosurgical service around Canberra. And so he was very, very busy, lots of aneurysms. I knew that term from age 8 or 10 or something. And a lot of head injury work, tumours obviously. And but he had this really calm demeanour. Nothing would rock him. Whereas in an emergency, I'm not good. I'm not your emergency or ICU physician. I'm more chronic care because in an emergency, I'm interested and I'll do the job, but I panic because I want to get the patient okay. So, yeah.
Where did you complete your training as a junior doctor, and did that have anything to do with you pursuing neurology in the future?
As a junior, yeah. So I stayed in Adelaide, and because I loved it, as you know, and I was playing cricket and all that. I just Adelaide was great because you saw everything. There weren't many major hospitals around. It was a feeder for places like Alice Springs and sometimes Darwin, Sapphire Field, and quite an older population. So again, I was in there quite early with dementia subtypes.
Okay.
So I Royal Adelaide Hospital, the old days, the old hospital. It was very intense work. It is now, of course, but boy, the hours were really long, and you learnt your trade really well. I guess physician training is all pretty intense, and I pushed on. I did a PhD while I was doing that, I did I don't know why, but I was doing I did medical science honours after third year. I was the only one in my year to do that. You could have that little break. There wasn't this sort of combined masters or approach of research with the program in those days. And then I continued as a part-time master's, translated to a PhD. Took a year off to complete that. So it was 7 years of kind of mainly part-time alongside my training and work. Got the PhD eventually in spinal cord compression, cell death, apoptosis. So there's cell death above and below the compression from either a tumour or an injury or syringomyelia. So that was my PhD, but somehow I then, of course, ended up towards more dementia as a field.
That's very interesting.
What's it like being a clinical neurologist, and what does your everyday kind of clinical experience look like?
Yeah, I'm 5 days in clinic, so out in private practice. So going through my medical training, I thought the world would be over if I didn't have a public job, right? Because you look up to your peers and you're like, oh gosh, I want to be in the department. And it was a fantastic department. But I did go away for my final year of training, sort of a fellowship in cognitive neurology and also sleep neurology, mixed with Parkinsonian disorders under Simon Lewis. So I had Lewy body dementia, Parkinson's and sleep disorders in there. I went away and then I met my husband and kind of here I am in Sydney. I would have gone on to a public job, I think, if I'd stayed in Adelaide. But here, lots of competition for jobs. I was sort of forced into private practice, but that was a good thing in the end. So dementia really suits private practice. There's obviously a lot of need of people wherever you are, public or private or any role in medicine. So you know that you're doing good work. There are lots of people out there who need your help and they're very thankful for it. And you can take your time in private practice. And I guess you don't have perhaps some of the traditional pressures of running a department, trying to get more money for your department, a list of 30 or 40 patients that you've got to care for when you're on call. So I'm on at Mater Hospital. That's a private hospital. So that works well. It works with family, although I'm the one working full time. I'm looking after my husband, who's a PhD student. But but it all works in really well, and that flexibility in private practice has been great for the times when I did go into a bit more research or a bit more lobby and advocacy over these last few years. When I was in medical school, so first 3 years, you didn't really do dementia subtypes. You called it dementia. That was about it. Okay. You said it was probably Alzheimer's. But here we are in the age of dementia subtypes and getting in and trying to treat things now.
And one of the national health priorities is dementia research. Can you tell us about how you're involved in that area and how it's changed since you've been in medical school?
Yeah, so I guess in terms of research, so the government is taking a more integrated approach for sure. Still, there's got to be a longer term vision on grants, particularly in the field of neurology. It's not an easy space to study. But there is a recognition now of patients are surviving their other conditions, their hearts, their lungs, and they're getting through to types of dementia. Aged care and the Royal Commission, of course, that has been huge, along with the investment of the government in research. So I have a PhD. I work with researchers largely rather than an academic, as I've said. And it's still really competitive for grants. You've got I think it's a 6 or 10% success rate these days. So very tricky.
Isn't it?
And then how do you fit that in with your clinical? It's always been the case. A clinician researcher role is tricky. So hats off to my colleagues who then become full-time academics, as well, and take that hard road. But anyway, it's been fantastic to see the investment through, and now, we're diagnosing Alzheimer's or frontotemporal dementia or Lewy body dementia or CTE, and we'll get to that. But with recently, just in the last month or so, the government's approved a treatment for Alzheimer's. So that will then generate a boost for further research, I imagine, in this new age of biologics that we have.
What is that drug, and how does it work, and what's it being used for?
So as I said, back in the old days, it was dementia. You couldn't do anything, as they said. Through my trade, of course, we quickly learned you can do lots of things anyway, with or without a treatment. You can validate people, you can get them on the right track, understand the diagnosis, help them sort their powers of attorney, their wills, all the legal documents, sort out their home. But now, finally, we have a disease modifier. So the old joke was neurologists can't do anything. They can't treat a patient right. Well, they can only give steroids, but that's just no longer the case. We knocked that out of the park with MS. Life expectancy nearly normal, with good early treatment.
It's amazing. And
the wheelchairs are, rates much less. Certainly we've had all these good biologics come through for inflammatory disease, but now neurodegenerative disease. This is the first cab off the rank. So it targets this drug or class of drugs that are anti-amyloid. They're MABs. They target the amyloid protein and they clear it from the brain. And it's given as an infusion once a month over a course of up to 18 months. And earlier the better. Remember, amyloid protein builds up 10 or 20 years before you get your Alzheimer syndrome. So you and I will probably have screening and then treatment before we run into real trouble in future. But at the moment it's given just for early Alzheimer's or mild cognitive impairment with amyloid on your PET scan, your amyloid PET, or evidence of amyloid on CSF testing. It might slow it down by 35%. It depends on this thing called your ApoE profile, which is your cholesterol genetics. And so if you've got an E4, homozygosity, you won't respond to this drug at all. If you've got one of those high-risk E4s, maybe a 25% slowdown. So that's the sort of early evidence around a thing called donanemab or Kisunla. So anyway, so we haven't even started giving it yet. Maybe by the time this is released, it will have. And usually these are well tolerated. They're targeted medicines. You're looking for hypersensitivity reactions with these infusions. I'm really interested to see how my dementia patients will handle having an infusion once a month, just the actual procedure. So there's going to be a lot of learning. We watch for a reaction in the brain called ARIA with these amyloid-related inflammatory changes of swelling or bleeds. So we do repeat MRIs every few months or more intensely. However, patients have not seemed to show too much clinical change, even though the scan might look terrible. So again, we're all learning and we'll see how we go with this drug. But it's an absolute breakthrough. It really is, if it proves itself in the long term here and if we see it before our eyes, that patients are remaining steadier for about 18 months through this Alzheimer's course. Remember, Alzheimer's, within a decade, unfortunately, there's usually death with it. I have got personal experience with my mother having Alzheimer's. Most people do these days have a relative with dementia. So everyone's really passionate to see this through, see what it can do, what good it will do. Yeah,
that's fantastic to hear. And it's so great to hear that this is just emerging now. And it's so exciting that we can see in the future how this plays out. Hopefully it's a great drug that does a lot of help for a lot of people.
So we're the cool kids now. So cognitive neurology was on the out.
Yes.
Now it's the most popular subspecialty coming through with the juniors. So
Truly.
yes,
I'm noticing neurology is increasing as a specialty choice, and also like just the kind of focus on it has been much more promising in these past few years. Now we can actually target it with more specific drugs. It's similar to oncology, where you
Yeah.
Which is what we were
Very
talking about
similar.
last episode,
Yeah.
precision medicine. So
Yes,
Yeah.
that's the word for it. And MS, right? Back in the 90s, beta ferron, that's about it. Maybe it was like the response was minimal or nothing, you know, and here we are with such good response now. So yeah, I think in 5 years it'll be different. In 20 years it'll be
dramatically different.
you know, wonderful.
That's so interesting. And you also mentioned that you have an interest in CTE. What is CTE? Could you explain for our listeners? And why are we really only starting to hear about this more recently in the media?
Yeah, so this might be a controversial topic. I don't know. Some people believe in it, others don't. It's controversial too because we've got these highly paid sporting codes. I mean, you know, big industries with lots of profit, turnover of hundreds of millions a year. So anyway, it's caused by repeated head injury. So it's a condition called chronic traumatic encephalopathy. Terrible thing to say. I don't know why we need chronic. We know it's, you know, anyway. CTE for short. During life, I diagnosed traumatic encephalopathy syndrome, or TESS, and I'll call it TESS/CTE. Yes, there's no sort of test to prove that someone has CTE pathology in life, which CTE pathology is tau protein build-up in the subsulcal regions, and then it spreads south to the temporal lobes and frontal lobes and beyond. The opposite pattern to Alzheimer's, which is right there in the CA1 of the hippocampus with amyloid and tau, different tau probably, and spreads out from there. So we think those subsulcal regions are vulnerable to the repeated head impacts.
Okay.
Remember, it's not just a direct head impact, it's like a whiplash or body lash during a tackle. So we think it's thousands of those impacts adding up over the years. And the number of years a person boxes or plays footy is a proxy for the risk of CTE. Certainly the earlier they start as well. So most of my patients who I think have CTE are into a 30-year exposure history of footy, dedicated country footballers. Doesn't have to be the top NRL players or whatever. And we see it across the codes. And soccer in the old days, they had the leather ball that was really heavy in the wet and lots of heading, and so that caused it. It's across over 10 sports now, though, wrestling and rodeo and so on. So anyway, it's a long dementia. It's a 20 or 30-year type process, in my opinion, where it starts with very subtle mood changes often. Memory will join in, language losses. The type of memory loss you get is this, what you and I are practicing, learning or working memory, episodic memory. Whereas Alzheimer's is a loss of memory across the board. You know, their retrieval's gone already quite early. In this, retrieval's quite late as it progresses into those temporal regions and frontal regions and globally when you get your atrophy. So there's low stage and high stage CTE. The lower stage with the mood I mentioned, again, that's kind of unique signature, different to any other type of dementia I've seen or situation. It's this upwelling of anger very easily, frequently during the day. Like somebody's left something on the table or somebody said something to that individual and they'll just flip 0 to 100. Really unpredicted, often not remembered by the individual. So the following day they're like, what happened? I don't know, that was fine. And their partner, or usually their wife, they're like, oh, really? You know, you flipped your lid. And I think, depending on their personality, that's either internal or verbal or physical at worst. Apart from that, there's this rise in anxiety, rise in depression as the condition progresses. You might have suicidality, and there's debate about suicide rates with CTE. But the memory loss and the language loss and then this global cognitive impairment progresses to a classic dementia type picture where someone needs high level of care, and then there is a demise with frailty or falls as the culprit, or losing the drive to eat, etc. over that long process. You can get it. The youngest they showed with pathology was age 17.
Wow.
But not the symptoms, right?
That's rough.
So there was also a rodeo rider in their 20s, so it can occur really early. I've got patients in their mid-30s who look for all the world to have CTE with, you know, dementia on their neuropsychology testing, which is really mapping it out, an MRI that shows atrophy, stringy cavum, septum pellucidum, in the absence of other types of dementia features. I look to a thing called FTG PET, you know, the sugar uptake, glucose label, and they get patchy frontoparietal changes and eventually more a global picture. And we track them over time. And if it were Alzheimer's, they would have been gone by now. We're in 2 or 3 or 5 years, and they linger on and on. And we rule out if frontotemporal dementia with our PET scan and the characteristics again. they're very nice in the clinic. The social cognition is preserved.
Okay.
They can still tell their story in the pub. It's just the same story, and it's a little more restrictive for language. So I believe it's real. Just my instinct, clinical acumen, and a clinical opinion. That's the only way you can diagnose it. Above a 90%, let's say, threshold of certainty,
Okay.
and that strengthens over time.
It sounds like what you're doing is a diagnosis by exclusion, as opposed to seeing this lifestyle factor and saying that could be a contributing factor. This sounds a bit like, tinfoil hat, but it feels like you're skirting around identifying traumatic brain impacts as the cause of this dementia.
Yeah, only because I don't have a test for the tau yet, or a set pattern or a panel of biomarkers, as we would say. Whereas Alzheimer's, you've got your amyloid, your CSF, etc. But yeah, so it is a little bit of skirting around. That's true, and a lot of exclusion. So we know, we treat for the depression, we treat the migraine, which can fog you and take your memory. And a third of patients with head injuries like this have migraine. That's another story we can talk about. Migraine and head injury, really common, untreated. And sleep apnea is another one.
Okay.
You will be inattentive and not quite at your best for language flow or memory, and that they're big burly guys. I have to mention I see the military cases too, and domestic violence, of course. Or head banging behaviour, right? So developmental disorders and intentional head banging or through trauma psychologically. So and we've tracked them over time. So we need to see a dementia decline process and non-imaging, as well as highly supportive. So we're not sort of guesstimating or estimating. I won't give a provisional diagnosis unless there's evidence of neurodegeneration with an exclusion of other causes. And Alzheimer's, etc., is easy to pick and exclude away. And then more certainty over time. And we treat them. So I'll often give them donepezil. I'll steady the mood with lamotrigine. Very low dose. If I can give everyone a message here today, it's that anyone with any spectrum of head injury, be it 1 or 10,000, go for low dose psychoactives. They respond better. They get paradoxical worsening at higher doses, and they're at risk of delirium for any hospitalisation with the higher doses.
It sounds like it has been a contentious thing with CTE, but it also sounds like you're really passionate about it and making sure that patients are getting the best outcomes that they can, which is really good to hear. You started and directed the Australian CTE Biobank. Could you tell us about what that is and what the purpose of that is?
Yeah, so we wanted to start getting that in-life data. So it's partly all of the, the profiles of these patients clinically, radiologically. We intend for serological biobanking or CSF. And need some funding, So it's a concept and a work in progress, let's say. But we have had some early papers in terms of radiology findings, and and we've tracked them now for over 5 years.
Wow, that's
so.
Really cool.
Have had some who have been shown to have CTE in the end. So while we're waiting for all of that research side, we thought we'd offer the care side too and get in there and support them. Being a unique pattern of dementia, and they're all pretty much peas in the pod or similar, right? So I just sort of instinctively thought they're going to go well in a support group. Bit random. I haven't run support groups for the other types, but I thought, because, you can have agitation, it can be tricky. These guys, as I said, social cognition's preserved. And it's a thing called Circle CTE we created about 4 years ago, actually at Macquarie Uni initially. And it's 8 to 10 patients in a room, and then the same of the carers as well, led by neuropsychology or neurology. And that has been magic, really. I mean, I've learned a lot through that process. They seem to really embrace it and love the sense of validation and getting all their tips, their resources, just hearing someone in the same boat after so long. Many of them haven't had a diagnosis for 10 years of symptoms.
Wow.
They often end up in a mental health stream, whereas this is, of course, in between or neurological.
Wow.
I can imagine that's so
useful and just so needed as well. So,
and also, like, for all the patients who are suffering from this condition, it can feel super confusing because, firstly, as you said, nothing really shows up scan-wise. So neurologists who might look at ordinarily someone way out of the age range for what would normally be considered like the age you would consider neurodegenerative diseases suddenly having like these random outbursts. And because it's anger specifically, and also it's like quite strong men usually, because they're the ones that go and bash together in sports involving traumatic brain injuries, they don't usually see it as something that could be caused by anything that they're doing specifically. And also a lot of what their livelihoods are based upon the sports that they are participating in.
Yeah, this is the art of neurology. You've got to weigh up that person in front of you. And I'm not hard down the line very often to say you must give up. Where I draw the line is if they've had evidence of a moderate traumatic brain injury, so bleeding or microhemorrhages or gliosis, that's evident. And I say, gosh, no. The next one could be residential care or worse. But on the whole, I would say I think there's been a shift. So I think already people have been thinking about this and intuitively know that head injuries aren't great. And what would I do outside of my sport otherwise? Most people are like that and open, and there's coaching or other sports. Mostly I've seen a transition to non-contact sports. They're still active and they're physically, I call it a physical cognition, these types of people who, what would they do otherwise? They just, I did sport, but I don't get up at 5 a.m. anymore to train. I'm not that pure physical cognition, but these guys do for life. They love it. So I understand we must provide that to them. So interesting social context. And then, of course, the sports, it is an industry, it's economy, and it's going to be here to stay. So it's been a really interesting lobby situation with government and stakeholders. How do we we don't want to kill off the sport, but we've got to edge it over those years. It's a year's project. We finally got to stage 1 where the government gave 12 million to CTE and said the acronym CTE. So that's wonderful. Next step is the research. Not necessarily for us, for anybody. Do the work in CTE. It will need $10 million to understand what we're dealing with in this country. How many people have played football for at least 20 years? Technically, you only need 5 years plus 2 years at the higher level for risk of CTE. So that's a lot of people in the country. So I'm worried about how much is out there. I think that because people are living longer, 80 is not that old these days, We're seeing the CTE come out now for those people who are in their 60s and 70s who should be living better and living longer. And we're like, oh, there's trouble. So I've got geriatrician friends, for example, who think they are seeing a lot of rugby league players or other codes. I won't name a code in the nursing home.
Yeah, it's like accumulated life risk as well.
Yes. So every head injury adds up. It's those subclinical concussions, subconcussions we call them, but subclinical mild traumatic brain injuries. So tackle after tackle, you do not have to have symptoms to have had a brain injury. In fact, we have very little understanding of the correlative symptoms, even a knockout, in terms of the severity of where, the region in the brain, the severity of cellular injury. We don't have those biomarkers yet. Okay. So I think I shared with you the Concussion Big 5. So slump, which is a knockout, slow to get up, sway, which is your ataxia, stun, so sort of confused appearance and slur, not responding normally, not their usual speech pattern. They're easily recognisable signs of concussion, whereas a lot of people get hooked up on the symptoms in the community and they say, well, I might have been knocked out, but then I recovered and I was fine. I haven't had a concussion. It's like, of course you've had a concussion, you had a knockout. Watch too for the tonic posturing. So this is cortical stunning or, loss of the usual inhibition across the cortex when they immediately have that knockout. So you'll see the sort of fencing posture, clenched fist, extended arm for some seconds, and, that is of concern of a more serious event.
And do you have advice for people who are playing contact sports, whether medical students or not? How can you protect your head moving forward?
Yes. Oh, goodness. Protect in other ways, firstly. Remember, careful with ladders. Cycling in Sydney, wear your helmet. And the headgear in footy, it doesn't protect from concussion. It'll stop maybe the temple fracture and the extradural. But the advice is to minimise where you can in any way. So usually training, so in soccer you could say, look, I'm not going to head the ball so much. Tackling, unless you're a really top player and being forced to do this, maybe you can work with the coaches in the club to be having this training exposure. Maybe you're not doing like 2 clubs, or a gala weekend where you've got 4 games or something like that. then consider your longevity in the sport, you know, and what are your other options? Do you want to push on to 30 and 35, or are you better cutting it at age 25, which I think is probably about right. Not official. As I said, I don't stop people playing. And certainly, how many concussions have you had? I mean, there's that debate. How many is too many? Nobody has a magic number. But if you've had 3 in a season, that's certainly these days deemed to be out for the season. If you're reaching 10 in a career, well, you know, you can say, gosh, that's quite a lot. But these are pulling numbers out of the sky. It's arbitrary. So we're excited that there looks to be research for a blood-based biomarker coming through. That's what we need to understand recovery, and also have these concussion passport concepts of how much head injury have you accumulated, say, from your mouth guard across your career. That's where we get to.
Oh, as in like just
like the accelerometers and
inside your mouth.
So interesting.
That is so smart.
Yeah, it doesn't exactly correlate as you might imagine. You know, you can have an earthquake and the building's fine, but it's a start again. And this is kind of where we're headed to, and a bit like radiation monitoring in radiographers, you know. So and just this, you know, I like to have introduced a little bit of neuroticism to Australia. Not a lot. We still want to get out there. I've got my kids playing hockey and horse riding. But we don't want to stop life, but we do want to be sensible. And if we, you know, as I said, there could be a lot of CTE out there, and risk of other neurodegenerative disease in the order of 3 to 5 times, Parkinson's, Alzheimer's, motor neuron. Just like alcohol. If we all didn't drink so much in this community, we'd probably avoid alcohol-related dementia and all of the other ramifications. So worth going for.
And where do you see neurology heading in the future, especially with precision medicine and all these new advancements coming through?
Yeah, I guess, as I said, we'll be cool for sure. It'll become more rapid, you know, and more prevention-based. So I imagine we'll become like endocrine, where you're almost preventing diabetes now with the new weight loss medications, and, you know,
GLUT1
Wegovy, etc. Yeah, so we aim for elimination, don't we?
Yeah.
We'd rather not be needed and have to work. So I think it's going to be, where it should be, prevention, earliest care. I think that across the lifespan, questions will become way more interesting, and obviously mixed with genetic risk. So that testing hasn't really quite landed for neurology yet. It has in terms of specific neuropathies, dystonias, or myopathies, or, you know, families with it. But in routine neurology day-to-day, not yet. But yeah, I think it'll be exciting to think, right, what are the genes, and what, right from in utero, what are the exposures that are adding up for disease, and where can we minimise that? So I guess the idea will be, well, eventually we'll probably live to 110 or 20 in the absence of too much disease, eh? And then I don't know what happens. I don't know after that. Do we just suddenly burn out one day? Will we develop those chronic conditions then? Do we want to live longer than that? I don't know. You know, it's this big societal debate. When we've got that very difficult debate, don't we, of voluntary assisted dying coming in. So we, you know, if we're asked about that, we have to refer mandatorily. So we do that. Dementia's a really tricky one for that.
Oh, yeah, because how would you know?
Yes. Yeah. Are you aware? Can you say for the future? You know, these are debates to be had.
So interesting.
I do want to say, just because it's so interesting that you mentioned like how lifespan expanding. I remember it would be around 10 years ago, there was this massive TED talk about like the telomere shortening thing. And then we just thought like, oh, that was the hard cap on like human like longevity. And as we like kind of remove like chronic diseases, we're kind of noticing the people that are able to live for the longest are the people that just are absent from lots of like significant chronic accumulated lifestyle risks. And it's kind of interesting because neurology is kind of in the field where most of your body is fine, and like it can heal itself quite well. The part that usually ends up breaking towards the end is your brain, because that's the part that doesn't regenerate itself quite as well, and the accumulated lifestyle exposure is precisely what ends up to kind of bite you in the end as you get better and better, and like modern medicine gets better with healing the rest of the body. Brain is the part that's kind of like the final frontier to hopefully increase lifespan that way. Is that kind of like what you've been seeing?
Yeah. Well, hoping for, right?
Yes.
So, I mean, we've been seeing the lifespan, of course. I've got so many 90-year-olds and beyond. I mean, my father-in-law included, 94, still looking after the whole family, cooking, cleaning, whatever. Thank you, father-in-law. You can cut that if you want. But yeah, I think we'll probably have neuroprotective medication of some sort and neurorepair, neuroregenerative. And then we'll probably have more bionic type stuff. I mean, we've got the cochlear implants.
Oh yeah.
You know, vision's going to get there. It'll just be exciting to see how can we enhance the senses, and that's important too, obviously, in a context of dementia or cognitive decline. So I just think, it really is brave new world already, and then where we'll be in 20 or 50 years. Or so every year when you do your registration, they ask you how long you're going to work for. And at the moment, I think I'm sitting around 80 or something. So where will we be then? I don't know. And will I be needed? Will we all be using our AI enhancements?
Oh yeah. Have you seen like any of the brain-computer interface like research across like the Neuralink just had their new announcement, and they've gone a lot of not to like bring too much press around it, but it's just basically like they've done massive advancements in what they've done. Have you seen anything along that stream in terms of brain-computer interfaces or connections?
Nothing where I've gone, oh, that's nearly there. But I think it's fantastic, obviously. I mean, it needs huge money that's being invested. I have seen recently this amazing neural mapping, you know, so really, I think you've got like 1 trillion cells or something that they can map out, and their synapses, their synaptic connections. And we learned from smell. So the great work that led to the Nobel Prize in terms of neural activation for smell sense, you know, because, and if you think about it, I thought about this the other month. I was like, a tiny little olfactory nerve cannot do it all anyway. So we already knew 50 years ago that was never going to be where smell was to a small part of the brain. It lights up for all different smells. So that neural networking, that understanding of the neurophysiology as a basis for the neuropathology and then targeted treatments, that's also where we'll get to. So there'll be a lot of neurotransmitter work, I imagine, probably, using precision medicine and biologics to get there, and then gene modification. So, I think we will know our brains on a microscopic level. That's the advancement that'll then treat these diseases.
Wow. And do you have any advice for medical students who are interested in pursuing a career in neurology?
Yeah, do it. Definitely, yes. I would say it's better than the plumbing and electrical of Bunnings cardiology. You know, like no offense to any of my cardiology colleagues, but I just love what I do. The brain is a final frontier in that way, and just endlessly interesting, and it's a people specialty. But maybe that's not your thing. You know, that's okay. So I think you know instinctively if it's for you, and if you really love that and be passionate about that. Do find your field where you're passionate in. I think that's important. Really helps. And try to, I would say, you have got your lifestyle factors and all the rest of it, but your passion for the field's what's going to hold you in good stead over that long career that we're all meant to have. So, that's right.
With our new targeted medicines, living to 120.
Yes.
And continually practicing till then.
Exactly.
No retirement for any of us.
No.
But thank you so much for coming on today, Dr. Mobbs. It's been a pleasure chatting with you, and such an interesting discussion about so many things in neurology. So thank you very much.
Well, thank you so much for having me, guys. It's been a real pleasure as well. And I hope that was useful, and good luck to everyone out there.
Thank you.
Nice.